This is All of It. I'm Allison Stewart, live from the WNYC studios in Soho. Thank you for sharing part of your day with us. I'm really grateful that you're here. Coming up on today's show, we'll hear some strategies for making and keeping adult friendships from New York Times style writer Laura Regensdorf, her recent article explores how to widen your social circle. We'll also hear from the Oscar-nominated sound design team behind the Best Picture-nominated racing film F1. And later, some Grammy-winning music from Duran Bernard, whose album Bloom earned him this year's award for Best Progressive R&B Album. That's the plan, so let's get started with the science of baby making. As a kid in school, you learn the basics of sexual reproduction, and especially you learn about the ways to avoid it. But the education most people lack is what happens when you're trying to get pregnant and it isn't working. Advances in technology have made it possible to have more control over when and how you get pregnant. Egg freezing is becoming more and more common. And yet many people go into the process of trying to get pregnant with very little understanding about the obstacles they could face. Dr. Lucky Seekon is an OBGYN and a reproductive endocrinologist and the author of a book called The Lucky Egg, Understanding Your Fertility and How to Get Pregnant Now. She's here with me now to discuss the options that exist for people trying to conceive and have kids. Welcome. I'm going to call you Dr. Lucky.
Awesome. Thank you for having me.
Listeners, our phone lines are open. Are you thinking about your fertility? Are you thinking about getting pregnant now or maybe down the line? Do you want to know your options for having kids and when is the right time? Or do you want to share your own experiences with infertility, egg freezing, or something else? Call or text us now at 212-433-9692, 212-433-WNYC. Dr. Lucky can't provide specific medical advice over the radio, but she can discuss fertility topics broadly. So you're an OBGYN and a reproductive endocrinologist. Could you explain the difference?
Yes. So I did the basic training to become an OBGYN, learn how to deliver babies and deal with all sorts of gynecologic issues. And then I went on to do further subspecialty training where I became an expert when it comes to reproductive hormones, the reproductive system, ways to diagnose and overcome different forms of infertility and help people preserve their fertility for the future.
So someone who wants to go to see an OBGYN would see you because?
If they're trying to get pregnant and it's not happening, if they want to look into things like egg freezing or embryo freezing, those are the big reasons that people come to see me.
And then someone who wanted to see you because of your expertise in REI would see you because?
Well, if they have problems like polycystic ovary syndrome, this is actually a really common cause of irregular cycles, irregular ovulation, and things like premature menopause.
You begin your book by talking about the fertility knowledge void. What is the fertility knowledge void?
So I started with that topic because I think in order to tackle a problem, first you have to identify it. And most people are walking around without realizing how little they know. And I think it's really important to call that out because it is kind of insane if you think about it, going through most of your life contracepting and wanting to avoid pregnancy and then having to do that 180 shift where all of a sudden, magically in our 20s and 30s, we have to start contending with what is our biological clock and understanding what that really means. You know, do we fall off a fertility cliff at age 35? Spoiler alert, no. But age does matter. And even the simplest starting step when someone wants to start to try to get pregnant is really understanding your cycle and knowing how to time ovulation because your attempts outside of that window are pretty low yield. So, you know, just knowing how to try is the very basics, and many people come to me for that basic knowledge gap to be filled.
You write that you begin every fertility consultation by breaking down the biological steps to becoming pregnant. How often is that information needed? It sounds like a basic, but it might not be for most people.
Well, I think it's the big equalizer. You want to set the stage and make sure that everyone's coming in with the same information. And I see a wide range. I mean, some people have come in and they have a great OBGYN that's done some of that education, or maybe they found good resources. There's a lot of people coming in with preconceived notions that aren't actually biologically factual. Yeah. And then there's some people that come in and they say, you know what, I'm so overwhelmed. I did a simple Google search and then I stopped because I started getting targeted ads. So I know nothing. Teach me.
Interesting. All right. Well, will you lay out those steps for us?
Yeah, definitely. I think the first step is acknowledging that human reproduction is extremely inefficient. And every cycle, when someone's trying around their ovulation, what's actually happening inside their body, there's a lot of magic happening in the background. We as women are born with a stockpile of about 1 to 2 million eggs, but at any given time point, only a very limited subset of those eggs can actually come to the surface and be recruited, so to speak. Mm-hmm. And then your brain sends a signal to the ovary. And like a lottery, one of those eggs that was recruited in that cycle gets selected to become the dominant egg that then eventually ovulates. So when you release an egg, that's called ovulation, that egg only lasts for about 12 to 24 hours. And so ideally, the timing should be having sex in the 3 to 5 day window in the lead up to the egg being released, because the sperm can survive in the reproductive tract, and there's millions of them, for up to 3 to 5 days. And so you're just trying to really get that window to line up. Everything else that happens after that point is largely out of your control. Not every egg will get fertilized. That's a complex set of chemical reactions that have to take place. Not every fertilized egg, and that happens in the fallopian tube, actually makes its way to the uterus and turns into an embryo. And not every embryo, even when it makes it to that point, is going to be healthy and able to actually implant or stay implanted. So something I always share with my patients is when you're in your reproductive prime years in your 20s, even then we tell you, don't expect more than a 20 to 25% chance of getting pregnant from a single ovulated egg in a given month. So persistence and trying over and over is really the name of the game. But it's important to know when to seek help. And if you're under 35, don't wait longer than a year. If you're 35 and older, because of the biological clock and how it affects your egg quality, your ability to ovulate a healthy egg, don't wait longer than 6 months. And in your 40s, you want to be more proactive and seek help at 3 months.
I wanted to say to bring out something you said. You said it's an inefficient system. Is that because of who we are as modern Americans, or has that happened over evolution, or is that just the case?
At baseline, like when you compare to other types, other animals or species, you think of, it being a sure thing. If an animal mates, it's going to have a litter of pups. Humans aren't built that way. We have access to one egg, and each egg is a bit of a long shot each cycle.
That's really interesting. Let's take a call. Kate is calling in from Harlem. Hi, Kate. Thank you so much for taking the time to call all of it.
Hi. Thanks so much for taking my call. I'm noticing that, and this includes myself, that a lot of women are freezing their eggs earlier, kind of as like a maybe I'll have a kid, not necessarily putting that as like something we're 100% going to do. And I fall into that category. Is there anything that the doctor would recommend that I take into account now, a little bit earlier, in terms of health, or anything that I might not be considering because it's not a 100% I want to have a child? Is there anything I can do now outside of freezing my eggs that would help me get pregnant in the future, if that's something that I decide that I want to do?
Well, I get asked all the time about lifestyle factors and, what are the things that, because so much of this, as I've illustrated when talking through the process, is out of our control, right? I always say it's like playing the slots when you're trying to get pregnant. You can control when you pull the lever and time things, but everything else lining up after that isn't in your control. So what is in your control when it comes to lifestyle? Well, just to break it down simply, anything that's better for heart health tends to be better for fertility.
Oh, interesting. Yeah.
So when you say, don't smoke, that's never going to be good for your heart health, your general health. And there is a link between that and depleting your eggs at a faster rate than what would naturally happen as a result of the biological clock. And it can be associated with a harder time getting pregnant, whether you're using treatments or trying on your own. Drinking, alcohol, really minimizing that is important. Studies have shown an association between drinking more than 4 drinks consistently each week and a lower pregnancy rate, whether trying on your own or with treatment. Maintaining a healthy weight is really important because that can affect your metabolic hormones and balance overall. And that can lead to, if one is overweight, it can lead to irregularity in the cycle. And if you're not ovulating or you never know when your ovulation is coming, it's hard to be in the game, right? So those are some big things. I think controlling chronic medical conditions, often overlooked are things like iron deficiency anemia, chronic asthma, autoimmune conditions. If those are flaring and they're not well controlled, that can also have an indirect effect on our fertility and pregnancy health.
This said, hi, I had my first kid at 38. Then we had secondary infertility after 4 miscarriages. Dr. Lucky performed my egg retrieval.
Oh, amazing.
We got 21 eggs. Only one went to genetic testing, wasn't a viable egg. But 3 months later, I luckily got pregnant naturally with my son. He is perfect. I hope you tell moms you shouldn't give up.
Oh, absolutely. I called my book, which is an all-encompassing fertility Bible, a guidebook, The Lucky Egg, not just as a pun because my name is Lucky, but to illustrate and admit that while science can get us very far, it really does just take one egg. And I've had patients who've had a hard time, even though they're using the most high-tech approaches when it comes to treatments like IVF, and they haven't had success, but they have been able to, in between cycle attempts, ovulate that healthy egg that they needed. So it's a fine balance between, cautiously optimistic and not wanting to sugarcoat and wanting to be, I think appropriately proactive, but also never giving up hope because, there are things that we can't explain even with all the science.
We have a call. Sherry is calling in from Montclair, New Jersey with a question. Hi, Sherry. Thanks for calling all of it. You're on with Dr. Lucky.
Oh, thank you so much for taking my call. And I do have a short time that I'm able to speak, but I'm calling on behalf of my daughter who lives overseas. And I know if she was here, she would zero in on this conversation. I had her at 35 years old. And then after many miscarriages, I had my son at 45 years old. And I never did infertility treatments or anything. But my daughter at 17 became a type 1 diabetic. So that's my question. She's now 35. I know she does want children, she told us. But what are the things for someone who has this condition? Is this something that's very dangerous? Is it something that she has to go into special care for? What would you say, doctor?
So type 1 diabetes can have a wide range of manifestations. It can definitely pose as a risk factor for some high-risk issues during pregnancy. But I want to encourage you and say I've had many patients with type 1 diabetes who are able to have, first of all, get pregnant and go on to have healthy pregnancies. And it's all about pre-pregnancy optimization. I always have my patients who have issues like type 1 diabetes be plugged in with a high-risk obstetrician and to get all the things checked. Does this affect their kidney function? Does this affect their heart, their vision? What is their current status before we get them pregnant? And what are the things we could be working on and optimizing? And I think with close oversight, it can be a really uncomplicated, straightforward journey, but it's all about having the right care team.
I'm speaking with Dr. Lucky Seekon, OBGYN and reproductive endocrinologist. She's the author of the book, The Lucky Egg, Understanding Your Fertility and How to Get Pregnant Now. Listeners, our phone lines are open to you. Are you thinking about your fertility? Are you trying to get pregnant now? Or are you thinking about it down the line? Do you want to share your own experiences with egg freezing? Our number is 212-433-9692, 212-433-WNYC. Dr. Lucky can't provide specific advice over the radio, but she can discuss fertility topics broadly. This was something that I did not know and it sort of blew my mind, that unlike other reproductive organs, the uterus doesn't really age, that a healthy uterus has the ability to support a pregnancy. Why is that?
That's a great question. It's one of my favorite facts to share at a dinner party. It's a very uplifting fact, which you need in a sea of really sometimes negative statements when we're thinking about reproductive aging, right? But everyone's seen headlines of women having children in their 50s and even beyond. And that's not necessarily without risk, because a lot of pregnancy complications can be linked to other things that affect our health, like our cardiovascular outcomes. As we age, the wear and tear of aging can reduce blood flow to a placenta, and that can lead to issues. But the ability for an embryo to implant and stay implanted is not related to the age of the uterus. Your uterus is a vessel. It's a muscle. And whether you are producing hormones from your ovaries or whether your ovaries are no longer in play and you're supplementing those hormones, the uterus doesn't really know the difference. And it's kind of like the soil. And as long as you have the seed to implant into the soil, you can have a baby, So this is something that I tell all of my patients. I have many patients that go into early menopause who come to seek help. Some of them have frozen eggs from before, or maybe they're using frozen donor eggs. It really is an encouraging fact, and it's one of the reasons why egg freezing and embryo freezing, when you're thinking about prevention and, preserving your fertility for the future, can work really well because you're kind of taking the time-sensitive part of your reproductive health out of the equation.
When you talk about egg freezing, can you describe that for us?
Yes. So remember at the top of this call, we were talking about how a bunch of eggs come to the surface and then only one of them is selected to ovulate. I know how to get to those other eggs, but I'm relying on your body to kind of bring them to the surface and make them available. And we can give women injectable medications that mimic that same hormone signal that normally selects and matures one egg to ovulate. And we can give it at a higher level to try to select all of what's available. And over the course of 8 to 10 days of shots, we're trying to mature and salvage as many of those eggs as possible. Just like a banana, when it's ripe, is easier to peel, when those eggs are mature, it's easier for us to extract them. So there is a procedure at the end of the 8 to 10 days of shots called an egg retrieval. It takes about 10 minutes. It's done while you're asleep, and there's no abdominal incisions. It's a very minor procedure done with a long, thin needle that goes through the vaginal wall directly into the adjacent ovary, and we drain each of the bubbles of fluid that contain eggs. We get the eggs out of the body. We can either freeze them as eggs, or if you have a partner or you want to use donor sperm, we can turn them into embryos up front and then freeze them as embryos about a week later. The thing about eggs is your freezing potential. I wouldn't call this an insurance policy or a backup plan. I think words matter. I would call this a head start. If and should you, for any reason in the future, need to rely on IVF to build your family, then being able to start with a larger cohort of eggs that we could access in one given cycle, and more importantly, eggs that have a higher conversion rate to healthy embryos, is going to make your IVF more likely to be successful.
People used to engage in this, especially people who had cancer would have their eggs frozen.
Yeah.
When did it become a more popular procedure for young women to decide, you know what, I'm 32, I'm going to freeze my eggs?
Yeah, I think the comfort level around it has changed as more and more people are doing it and talking about it. But also a technical factor. The experimental label on egg freezing was lifted in 2013 by the American Society of Reproductive Medicine, because in order to say something is no longer experimental, you need enough cases to be able to study and say, let's look at the outcomes. Okay, this is actually something that can help people build their families. And the technology really improved around that time. We started doing something called vitrification, and that's a much more rapid freezing technology that really improved success rates with thawing the eggs, and pregnancy rates were also improved. And so, now when we thaw out eggs, about 90% of them will survive the thaw. And while not every egg can make a baby, just like the situation we talked about with human reproduction being inefficient, that inefficiency doesn't magically go away just because you took the eggs out of your body and you froze them. And that's a conversation that I spend a lot of time on when I'm counseling people about egg freezing and the expected outcomes if and should they ever come back to use those eggs.
Let's talk to Claire, who's calling in from Manhattan. Hi, Claire. Thanks for taking the time to call All of It today.
I just wanted to add, I have grown children now, but at the time I was going through all of this, I had all the workups done because I sort of woke up late and suddenly went, why don't I have 10 children impregnate me now? And so my GYN, we did all the various tests to make sure I didn't have any underlying problems. But what nobody talks about is men often have health issues that are hiding that affect your ability to conceive. And in our case, my husband had underlying health issues that were contributing to his not feeling well and also to our ability to conceive. So while we talk about the egg and women's side, it's also important. It takes two to make a baby. And what I went through was, we'll do all your tests and then we'll ask your husband, because men are more sensitive about this. Well, hopefully things have progressed, but don't leave the men out. Sometimes there's something going on, whether it's a medical or an infection, or smoking is not good for sperms having a sense of direction. All these things which we don't talk about. We only talk about the female side.
Claire.
That's all I wanted. I was fortunate that we worked it out and I was able to skip the overwhelming part of IVF, which it was at the time. But they also don't, we have science available, but it is a lot. And I think that people should understand it younger so they know what they might be heading towards if they start late.
Thank you, Claire, for calling in. Yeah, what are the first questions to ask about male fertility? And what are the common misconceptions that people have about male fertility.
Well, I absolutely echo everything Claire said. And she's absolutely right that there was a time where it was commonplace to really focus on the female partner and then kind of say, okay, well, if nothing checks out, then let's check out the male partner. And that's just so foolish. 50% of couples with infertility have a male factor, and there could be a combination of factors. And the test required to evaluate male fertility is so cheap and easy. It involves having them provide a sample and looking at it under the microscope. It's not an expensive test. And a lot of times we can, from the get-go, recognize, if there's a problem with sperm production or the quality of the sperm. And guess what? Men make new sperm cells every 74 days. So there's room for improvement. And so there's every reason and motivation for us to really recommend upfront testing for both partners. In some cases, up to a third of cases, will have an isolated male factor. So you may know someone in your life that's going through IVF, and they don't even have any issues that have been identified on their testing. It's more just a male problem. So I think the first step is testing. The second thing is exactly what Claire was saying about lifestyle. All the things that I was talking about that are better for heart health, that are better for fertility, that applies to men and women. And beyond getting someone pregnant, there's a real rationale for focusing on male lifestyle and health. We know that there is a major male contribution to the genes that make up the placenta. The placenta is this magical temporary organ that connects mom and baby and provides nutrition and oxygenation to a growing fetus. And there have been many studies over the past decade that have linked chronic, uncontrolled medical conditions, certain lifestyle behaviors that are unhealthy, to not just health outcomes in the child, but also potential pregnancy complications in their partner, because so many pregnancy complications stem from placental issues.
We have a text here that says, I was told having acupuncture can help women when they are being inseminated. Is this true?
So acupuncture is a form of ancient Chinese medicine, and a lot of my patients do acupuncture. Now, do I necessarily recommend it and say this is going to make or break your attempt? No, because the data does not show that it moves the needle, pun intended, when it comes to improving pregnancy rates, whether you're trying on your own or with treatment. But it's not harmful. And I myself, as a Western medicine doctor, have done acupuncture because I find it very calming and relaxing to be in a quiet room where no one's allowed to bother me. And, it might be placebo effect, but I think it's definitely not harmful. If it's something you want to do, go for it. But I certainly wouldn't push someone who is leery of needles and feels like it's just adding to the burden of treatment. If they don't want to do it, I don't think it's going to be a big deal if they don't.
Eastern meets Western, why not?
Exactly.
My guest is Dr. Lucky Seekon, an OBGYN and a reproductive endocrinologist. We'll have more after a quick break. This is All of It. You're listening to All of It on WNYC. I'm Allison Stewart. I'm speaking with Dr. Lucky Seekon, an OBGYN and reproductive endocrinologist. She's the author of the new book, The Lucky Egg, Understanding Your Fertility and How to Get Pregnant Now. How should someone pick out a fertility clinic? What are the green flags? What are the red flags?
I have a whole chapter on this in my book. It's probably going to be deemed the most controversial chapter, right? Because I kind of just put it all out there. And the way I approached writing it was I thought to myself, if my sister or best friend living across the country wanted my help to suss out what are the clinics in their area and, where should they go, here's what I would tell them to look for. And, I would start by looking at success rates. A lot of people aren't aware that there are places to find this information online, and it can be very opaque and hard to interpret. But I think looking at live birth rates per initiated IVF cycle and comparing within the same age group, between different clinics within the same city where you presume, the patients are similar, right? I think that just looking at the relative differences can kind of point you in the right direction of which labs might be better, because a lot of people don't realize that it's not just about the clinic and the doctor and whether they have good bedside manner. But there's a whole team of people called embryologists that work in the lab. They're the ones handling the eggs and the sperm and the embryos. And it's not just about their skill, but also the level of quality control in the laboratory environment. Everything is so nuanced, and not all labs are created equal. So I would say that's like the biggest thing to look at. Then there are a list of questions that I put in my chapter. You really want to understand is who you're talking to, are they adhering to the standard of care? Are they typically putting back one embryo at a time? Because we really try to minimize the risk of high-risk pregnancies, twins, triplets. That's become a thing of the past if you're practicing modern-day medicine, right?
Interesting.
And so I think there's a lot of inside tips and information about things to ask about that people don't even know. It's not on their radar. And I think obviously having a connection with your doctor, I think word of mouth recommendations are probably more trustworthy than online reviews, which can be very polarizing because what kind of people are writing online reviews, right? Either people that are very, very happy or very unhappy. So I think getting a recommendation from someone you know, knowing what questions to ask at the first visit so that you're not blindsided because you might have a great first consultation.
What's an important first question to ask?
Well, you might have a great first consultation where you feel like all of your questions were answered up front. But what happens at, 10 p.m. on a Wednesday night when you're in the midst of your IVF cycle, when you have a medication question? So knowing, how do I get in contact with my care team? And if I want to ask my doctor a medical question, is there a direct channel? Do they give their email out, their phone number? Is there a portal? Asking that up front can help you understand what your level of access will be so that you're not panicked or blindsided later down the line.
Let's talk to Donna from Washington Heights. Hi, Donna. Thank you so much for calling all of it. You're on the air with Dr. Lucky.
Hi. Can you hear me okay?
Hear you great.
Okay, great. I was actually an older mom, and at 40 years old, I went to my doctor, and she said, I don't care if you're married or not. I was living with my fiance at the time. She said, start trying. And I ended up having 4 miscarriages. I had 2 myomectomies for fibroid tumors, okay, and I want to say that because I had all the odds stacked against me in terms of age and 2 surgeries. And we went the IVF donor egg route because they told me that my eggs were gone and shriveled up and I wasn't going to get pregnant, so we did that. And my husband, by the way, is 8 years younger than I, so that's why I went to this extent, though he was a dream about it. He said we could travel the world or adopt or if it didn't work out. So we go to use the donor egg, his sperm, fertilized embryos, implanted approximately February 12th. I remember it was around Valentine's Day. By April 4th, I had had a miscarriage of the first embryo transfer. And by June 8th, when I wasn't getting my period again to cycle, because you need to cycle again, I went in for a blood test, and at 4:30 got the call, are you sitting down? You're pregnant.
Wow. That is such a good story. Donna, thank you so much for calling in. And I did want to bring up the issue of egg donors before we run out of time. When is the right time to consider a donor egg?
There's really no one-size-fits-all answer. I think the simplest answer when we say, yes, we recommend donor egg is in situations where someone is in menopause. They are no longer releasing eggs, and their egg count is so low that I can't use the shots of medication we were referring to earlier to stimulate the ovaries. The ovaries become very resistant. So in that case, donor egg is the best option, right? But for those kind of in-between cases, like what Donna was describing, where you have the eggs, your ovaries are functioning, but there are major challenges that you're up against with egg quantity and quality. I would never at the outset, based on someone's age or, if their egg count's low, say, you need a donor egg. We don't know until we try, right? And I think it's important to be upfront about here are the statistics in terms of your odds of success with IVF given your age and your numbers. But I've seen really great things happen where people overcome the odds because a statistic is one thing and the reality of the random collection of eggs that we have access to in a given cycle, sometimes that can pan out and defy the odds, right? So the difficult thing about IVF, one of the hardest things is when you're going through it, I don't have a crystal ball. And so we're doing the best we can with the information we have, but you kind of have to go through it to know what's going to happen. And if someone's gone through it and they're never able to respond to the medications or get to the egg retrieval, or their eggs are retrieved but never turn into embryos, beyond a certain point when you've tried everything, at that point, that conversation may be the next one to have.
Last question for you towards the end of the book. The end of the book, you concentrate on mental health. Why did you want to make that the final chapter of the book?
Because of my own journey. I went through secondary infertility, and I had actually gone through IVF to try to make embryos and was blindsided when I had a cycle that was canceled. They said, you're not responding, so you're not going to go through with the egg retrieval. I had a cycle where I got 2 eggs retrieved. None of them turned into embryos. And I went into those attempts extremely cocky, thinking I'm an expert. I mean, I'm doing this with my colleague in my clinic. It's going to be great. And even when I tried to intellectualize those outcomes, I found it extremely difficult from a mental health standpoint. And I felt like I did something wrong. All the advice that I give my patients, all of those human nature tendencies bubble to the surface regardless of my knowledge and my expertise. And so if I thought to myself, if that blindsided me and was so difficult for me, an expert who should be completely equipped, how does the average person go through this journey with all the unknowns and the waiting? It's very excruciating. And it's, for a lot of people, a marathon, not a sprint. And there are studies that have shown many people will drop out of treatment prematurely, not because of cost or finances, but often it's the psychological toll. So we have to do better as clinics, as doctors, to arm our patients with resources and tools so that they can be more resilient. And it's not just about the destination, it's about the journey and really trying to keep your sense of self intact and protect your quality of life.
My guest has been Dr. Lucky Seekon. She's an OBGYN and reproductive endocrinologist. The name of her book is The Lucky Egg, Understanding Your Fertility and How to Get Pregnant Now. Thank you for being with us and for taking listeners' calls.
Of course. Thank you for having me.